All right, so I wanted to do another quick poll, our last one for today. All right, so of the 5 subtopics we address with the Center for Dignity's work, what tools or strategies do you think are most needed to make real change? And we talked about each of these throughout my summary. Which do you think are most important? Okay, we'll give it another 15 seconds or so. Man, I hope we have this type of voter turnout in a few weeks. That would be good. We're up to vast majority of people voting. Okay, let me end it and share. So interestingly, vast majority of you feel like more awareness about the role of ableism in healthcare would be important. And also a fair bit different laws and better policies. And I would agree with this this kind of prioritization, because while I definitely feel that laws and policies are critical, especially to reframe them when they're just blatantly discriminatory, but as we've seen in several of our challenging examples, they're not enough in many cases. We have to take it further than that finish line. So thank you for engaging in that. All right, and for our final section here, I wanted, as promised, to address some strategies to address healthcare inequity. So I did say I wouldn't leave you hanging with just kind of all of our work to do, but also with some ideas about how you might work on some of these issues and how we'll continue to work on them as well. All right, so the first one, which is a fascinating and free measure if you haven't done it before, is called Project Implicit. And so this link takes you to a Disability Implicit Association test, IAT. And as a psychologist, I had background in what the IAT was. I always thought it was kind of this sort of wacky, like quick comparison on the computer of how quickly you respond to different images that are flashed up. And with the Disability Implicit Association test, they're actually disability related symbols and imagery. So the idea is that it's supposed to get at the deeper levels of our brain, not what we consciously believe we think about different groups of people, but more so how quickly our brain responds. And that if our brain is a little bit slower to respond when it's categorizing an image of disability into good or bad, then that tells us something. It tells us that pause means something. So there's lots of questions around the IAT in terms of, you know, how valid is it as a measure? It definitely shouldn't be taken as, you know, the one and only way that you measure someone's bias. And usually you take this as your own personal information and don't share the results. But increasingly, I'm encouraging some of the work that we do with residents and in medical training to take this Disability Implicit Association test. And there's a number of others on the Project Implicit website related to race, gender, ethnicity. There's several different ones on the site that you can see and compare results to. But this is one way to start talking about those implicit and under our consciousness attitudes about disability that can influence decision making. And specifically, I aim this towards healthcare providers to just learn more and talk about these things. And how I approach it is again, they usually keep their results private and we talk about what they thought of the findings. Another topic that I cover in working with residents in training or other healthcare professionals that are in their training phase of life is around medical discrimination. So the idea that decision making by healthcare providers can result in inequities and that these are avoidable differences. And what I try to emphasize, because we also know from brain science, is that people don't learn and they don't change their behaviors when they become defensive. So in part knowing that and trying to be strategic, but also because it's the truth that usually medical discrimination is not intentional. So I always start off with that to try to lower the defensiveness of healthcare providers so that they'll hear and hopefully change behaviors, which is the ultimate goal. But I also emphasize that while unintentional, the impact can be significant. And so it doesn't really so much matter whether it was intentional or not when it results in potentially the end of someone's life. So we really hone in on our work with trainees around two ideas. So one being quality of life and the other being prognosis. And I think this quality of life issue came up in the chat box, but there's a number of research findings that show that there's no significant, so statistically significant difference between ratings of quality of life from people with disabilities and those without. When you take the large samples, there's not a big enough difference that it comes up statistical in any way. When we hone in on some of the smaller studies where we see some lower ratings from people with disabilities, we realize that the social correlates of disabilities account for some of those differences. So when you ask somebody related to quality of life, how much do they feel a part of their community? And they may rate that lower. And when you look a little bit more deeper, especially in studies that have a qualitative component where we have some words that add to those numbers, we learn that someone may say, well, I don't feel part of my community because I live, far out from what I view as my community, and I don't have any transportation. So that's not so much as having inherently a lower quality of life. It is as much as it is a social correlate of the barriers that disability brings to our life due to society's structure. Not so much just having a disability equals lower quality of life. It's also fascinating that many people assume, again, think back to that common sense ableism, that the more severe a disability, that the less quality of life someone would have or the less satisfaction they would have with their life. And that is also not true. So multiple studies summarized by Gill, a 2000 study show that satisfaction does not diminish with increasing degree of disability. And sometimes this inaccuracy is perpetuated when people are asked about how they feel about their disability right after acquiring it. So when one acquires a disability, it certainly takes some time to adjust to that disability. But when you're not capturing someone's comparison of their life before and after a disability, you're more so looking at their long-term experience with disability. The satisfaction is not hinged to severity. So you can't make these judgments of, well, this person has a disability that's much more impactful in their life, so they must be less satisfied. That's not what science tells us. Quality of life, you hear that word brought up a lot in some of these really challenging medical decisions. And one thing that we've realized is that the way that people measure quality of life can be problematic with disability, because one of these aspects could be impacted by disability and it can throw off the whole measure. So for work example, we know that there's high unemployment rates of people with disabilities, but that's not only due to disability, that's also due to our society's ableism and exclusion of people with disabilities in the workplace. So not only are the measurements of quality of life problematic, but in most cases that we've talked about today, we're not even talking about actual measures of quality of life. We're talking about assumptions about quality of life. So this graphic here has some different spheres that are, when you give a measure of quality of life, there would be different scores and they would all combine. So things like belonging, emotional well-being, health, and they would all combine to give a total score.
Kara, I don't think we can see that graphic.
Oh, really?
Yeah.
Okay.
I wasn't sure, but I don't think you're sharing. You may
Can
not
you
be
see
sharing.
this? Oh, okay. Let me go back. I'm talking about my own screen here then. Oh my gosh. Well, those slides were not very exciting, so it's okay. Thanks for letting me know. All right, so I'm going to catch us up. This is the Disability Implicit Association test that I mentioned. And then I went over medical discrimination. And then we started talking about quality of life. So this is the graphic here. I think you can see now. Sorry, I forgot to share after our video discussion. So you can see that these different measures flow into the quality of life, but if one of them, like the work, was off, it would mask a more true estimate of quality of life if we took out barriers related to disability versus disability itself. So we think that this, something like this graphic might be more representative in terms of, and just to give an audio description of this, it's a more holistic view. The person is in the middle. There's considerations for immediate circumstances like relationships, work, and volunteering. There's consideration for my wider environment because we know that laws and policies impact people's quality of life as well. And then there's parts of me. So, and you can see that all of these are more holistic and balanced versus like feeding into one number that could throw off. But again, in most cases, we're not actually measuring quality of life when we hear healthcare providers making decisions based on it, which is why you really have to hone in and say, are you talking about actual quality of life or what you believe a person's quality of life to be? Because those are two very different things. A quick note on prognosis too. So in my disability community, there's a common occurrence of parents of children with osteogenesis imperfecta being told that their baby won't live past certain amounts of time. They're always kind of obscure times, sometimes like numbers of hours or days or whatever it may be. And that's common with a lot of disabilities. So I just Googled, doctors said I wouldn't live. And even for Google, this is a high number of results. So, so 155 million results of different stories published across the web about when doctors told usually parents that they wouldn't live, and that story is passed on. So the challenge here is that prognosis is actually something that healthcare providers are just not accurate at doing. But at the same time, when I hear their side, I hear them say, we are pressured to give a prognosis. People want sometimes more than anything to know what to expect. And so we know we may not be good at making a guess, but we try to give them that comfort. So there's that pull between what families want, but then what they get may be a very inaccurate estimate. And some people reflect on this and say, you know, I was given wrong information about my child before he or she was even born. And really that started my distrust in the healthcare system for valuing the life of my child because they counted him or her out before she was even here. So this is the risk of prognosis. And, you know, I think we're going to have to listen to each other in terms of healthcare providers and patients in terms of what's the best answer to this. Do we tell people, I wish I could tell you, but we're really just not good at estimating this? Or do we try to get more accurate in some way because one way or the other, it's problematic. Another important term that you should know for your advocacy around this effort is diagnostic overshadowing. And that is the idea that the tendency for practitioners to attribute unusual behavior, thoughts, or feelings to, in this slide, I've got the example of a person's intellectual disability. It really could be any diagnosis and not a separate mental health disorder. So we know that people with intellectual disabilities have around 4 times more likelihood, the chance to have a mental health disorder as well, but they're significantly underdiagnosed. So again, there's that overshadowing bias that means people miss diagnoses and they might wrongly diagnose based on this idea. So undertreatment and mistreatment as well. And another example that I share related to this is actually could be misdiagnosis, but when my daughter was born, because my husband and I share the same type of genetic disability, she had a 75% chance to have our disability. So one of the doctors on staff in the unit documented what the doctor believed to be facial features of our disability. And that doctor didn't know that we already had some testing that determined that our daughter did not have OI. But it was interesting because the doctor documented facial features that I have. So in this case, they wrote down like a prominent forehead and a thinner upper lip area. So, you know, yes, my daughter looked like me because we share genes, but she didn't necessarily have facial features of OI. She had facial features of her biological mom. So in that case, I was able to clarify and say, oh, actually, we had genetically learned that she does not have OI, and they, you know, kind of recanted her observations she thought she'd made. But so some collaborations and complementing efforts that I wanted to share with you all. We are really excited about a new ACL grant that is going to complement our work, led by Rush University and a number of partners. It's called Partnering to Transform Health Outcomes with Persons with Intellectual Disabilities and Developmental Disabilities, so PATH-PID, I think is their acronym, how they might spell it out, PIDD. But so you can link to that press release. It was just announced October 1st. So this is a brand new partnership. They're going to focus more on the curriculum and the training of the workforce side of things, whereas our focus is kind of post-graduation and after people are in the healthcare world. Another place on the web that I wanted to point you to is this hashtag Docs with Disabilities. So they're very active on Twitter, but there's also some websites that have spun off from this. And this perspective about what it's like to be a healthcare provider with a disability and work in this landscape where there's some pretty pervasive ableism can really add to our discussion, and we're figuring out ways that we could work together and support each other's work. And there's a great NPR interview, if you're up for it, about what medicine can learn from doctors and researchers with disabilities. All right, and I tried to kind of conclude on some high-level strategies in terms of what can we all do. And we can be aware of our own biases and attitudes. We can speak up. We know that inequities are not the same as disparities. So some disparities may factor into some of our disability-related health outcomes in general, but inequities, again, are when assumptions or ableism, discrimination are driving those differences. We can speak up. We can portray people with disabilities as empowered citizens, and not just in healthcare settings. We all need more examples of this so that we can counter that smog that I referenced at the beginning of our talk. We need more positive examples everywhere we look. We need to improve accessibility for patients. Even though that wasn't our primary focus today, it can't be overlooked. If I can't get into an office, then I certainly can't get equitable health care from that medical provider. You know, many of the other facets of our work in disability advocacy, like community integration, overlap in what we see in healthcare sectors as well. So promoting community integration in our schools, in housing, employment, and legislating against discrimination, taking a proactive stance, not just kind of addressing media getting issues, but also those less kind of less attention gathering issues as well. Empowering patients and people with disabilities, and when we overlap those two, having high expectations, and again, serving on those hospital ethics committees. So finding if your ethics committee has a representative with a perspective related to disability, and if not, serving or volunteering to help find somebody to serve. So I did want to share my references that I had, but in closing, I also wanted to share a lesser known but important quote from Martin Luther King Jr. Of all forms of inequality, injustice in healthcare is most shocking and inhumane. And I think that while you've learned hopefully much more about inequities in healthcare faced by people with disabilities, I hope that it will continue to shock us, because it should shock all of us, and it should motivate us to work and learn together on this issue for change. So identifying and eliminating the healthcare inequities experienced by people with disabilities should be a priority for all of us. We've talked about a wide range of topics today, from prenatal diagnosis all the way to end-of-life care, including, we've also talked about COVID-19. We all know that our healthcare system as a whole needs improvement, and many would say just it needs a total transformation. But without recognizing the ways that our disability community is already treated differently due to ableism, we'll be left behind in that transformation as well. So I encourage you all to learn more about these issues alongside me, alongside our Center for Dignity, and work together to equalize our chance to better healthcare so that we can all get out there and live the lives that we want and also deserve to lead. Thank you so much for your attention today, and I hope we have some great questions in the Q&A box. I'm going to turn my attention there, but feel free to add them if you haven't already. Okay, let me start. Are hospitals using their ethics committees to make these COVID-19 decisions, or are the doctors making these decisions on their own? That's a great question. So I think there's been different approaches that I've heard of. Some hospitals have used their ethics committees to either develop and or approve their approach to this. And some of those different approaches have been, if the hospital enters a shortage period, then a committee that doesn't see the patient will make a decision. And the hope for that is that by seeing the patient, you're influenced by your bias related to race, gender, ethnicity, socioeconomic status, disability. So the idea that is if a committee looked at someone's medical status only, could they make a more fair decision about who would get treatment if the shortage situation emerged? So some hospitals have decided that that's the plan, and they've kind of outlined the details of that with their ethics committees. But I mean, I don't think there's any question that in many cases the decisions made at bedside are coming directly from that provider to the patient. I mean, hopefully they're influenced by the policies of that hospital, but I also recognize that with the, with the influx of these systems and the strain that they're under, it's not something that they're going back to their ethics committees for every patient for. So I think it's a mix. But that's a good question, and an important one about different ethics committees have different decision-making power in hospitals. Some have very little and others have stronger influence. I have a question from Jacob. What is the website to find these implicit association tests? So if you look, I believe it's called Project Implicit. I think it's a part of Harvard's website, but if you Google Project Implicit, you should be able to find it. You can also find the background and what the results mean that way as well. All right. I'm going to try to look in the chat box. Yeah, do you see anything?
In the chat, we do have Mary has a comment.
Okay.
And the comment is, I've watched a lot of webinars since COVID started, and this is by far the most informative training I have seen.
Oh, thank you.
It's a comment, not a question.
Thank you. Yeah, it was a lot to pack in, so I hope that it was helpful, and I know it could have been more time, but I was already intimidated by 2 hours, so this was great. And I see John Munnis. He is one of our USAID CAC members, so good to see some familiar names in the chat box too. I see a question from Kelly, but I'm not sure I know what CRC is. Is that maybe CEUs? Well,
where is that one? A recent chat?
Yeah, it's how do we get CRC?
Oh,
Kelly's
yes. Kelly, if you contact me, walt.bauer@uky.edu, we'll get you those. That's a CEU question.
Okay.
That was a CEU question.
Yeah, and thank you for all the kind words we have in here. Oh, I see a question up here from Catherine in the chat box. So she works in a childhood education setting. It's more of a comment. So talking about the way she talks about disabilities, framing and what people can do, what they can help with. So trying to start with that positive representation at an early age is important. All right, and I know we're coming to the end of our time. I really encourage you to reach out to me. I've got one last slide here with my contact information, and also connect with us on social media. We're probably most active on Facebook. We do occasionally join we have some Twitter chats coming up that we're excited to join, so you could follow us there too. But feel free to reach out to me via email. I know I shared the Center for Dignity email earlier as well. That one's fine, or this one, it doesn't matter.
As advertised, this has been great. It's been an honor and a privilege for you to join us today. So I'd like to thank Kara for taking time out of her busy schedule and sharing her knowledge and expertise with us today.
Yeah, thank you so much, everyone. Have a good weekend.
Have a wonderful weekend. Be well. Stay safe.
Yes, for sure.